Welcome to today's webinar resident series, Implementing Locator Overdentures into Your Practice. This is a two-part series, so this is part one. The lecture is being presented by Jeff Carlson, CDT.
So without further ado, Jeff, please take it away.
Thank you kindly, Adam. Hello, everyone. I'm so happy to join me this morning. Got your coffees going, I'm sure. I got mine going. Let's get right into it. So this is part one. And so I think the way we start, I have to just do my quick disclosure that I am a full-time employee of NDX. I'm being paid to be here to do this, but that's about all I got for y'all. Let that soak in. You ever heard it called an oral wig? We've been calling these dentures that for many years. But again, where your challenge is, I think, in your part of in your stage of your career, and it's everyone's challenge, not just the younger dentist, but even experienced clinicians. The challenge is really trying to understand your patient and understand how they got to where they got, where they're looking to do, where they want to be from where they are now, so to speak. But you think about it, this is a billion-dollar market with all these adhesives. And it's a sad thing to think that someone spends all this money for a new denture and the expectations are probably, well, it's not going to really fit real well, especially lowers, right? So you have an opportunity to really help improve the quality of patients' lives. But I think where I was starting to get to is understanding the patient's why. My friends, this is so critical. Take a few moments in doing this. Implant dentistry, dentistry as a whole, really, but implant dentistry, and then when we get into this full arch type of dentistry, this is really, you don't change someone's life really with one implant crown, a single tooth crown, a 3-unit bridge, things like that. But when you get a patient that can change their social life because now their dentures don't come out of their mouth when they laugh or when they speak, eating's a problem, so they don't do social events and things like that. You have a wonderful power and the ability and a skill to be able to change these patients' lives. But the important part is to understand their why. What we mean by that is what's their motivation for treatment? And then not only what's their motivation for treatment, and if they say, oh, it's because my dentures keep coming out, wonderful. Let me ask you something. If we could keep your denture from being propelled out of your mouth when you sneeze, when you laugh, when you sing, or whatever it is that they say their ruin is, their real hot button is, say, okay, that's great. If we can do that, is there anything else that you would like to see as a result of this? Keep asking questions because it's about peeling back some layers because some people are very close, hold their cards close. You think it wouldn't be the way that they would be because you're there to help them. But some people are just not real good about opening up. They're embarrassed about the conditions they're in. So showing some empathy with the patient, not sympathy, but empathy with the patient, it goes a long ways. But you really should know this going in, what their why is and what their expectations are, because that's like going on a trip and knowing what your final destination is. If you don't know where you're going, how do you know when you get there? And then how do you know how to plan to get there? So it's very important. So the why sets up the whole reason you're doing this. Without the why, everything else you're doing really is mental gymnastics. And this really seems fundamental, you would think. However, what happens sometimes is the why isn't discovered until if you're the restorative doctor in this process and not the implanting clinician, that if the why isn't discovered earlier on, I mean, in other words, prior to surgery, then that's going to leave you in a more difficult position because after surgery, anything that you're going to try to do to meet that patient's why has to be done prosthetically. And that becomes a little bit more limiting because you only can do so much. The implants are where they are and you can't change that. So what we're focusing on this morning is going to be patient selection, which is really critical in an overdenture treatment. And I'll explain as we go through. and then, the patient expectations, identifying that, some basic biomechanics, and then some keys on the implant position. We're going to talk about part two on my last slide of this to explain what we're going to do next month on the 14th. All right, so I've been doing this a long time. I've been in dentistry over 40 years. I've been in implants for about 30 years. And I've been very fortunate. I've written a couple of books, lectured internationally on these topics, and worked with some top clinicians. And what we learned many years ago is still true today. And we created a four-step pre-surgical, that's the key word here, is pre-surgical process for really, helping you with the patient selection. And so it's a four steps. And step one is the patient's expectation. Step two is the restorative options. Once you know what the expectations are, what are you going to fabricate to meet that expectation? And then the third is going to be biomechanics. How do you design that restoration to meet the patient's expectation? And then the fourth is going to be the team concept. How do you share all this information, one, two, and three, with the implanting surgeon, if that's not yourself, with the laboratory, with the implant reps, the implant manufacturers, everyone involved in the team. So let's dive a little bit deeper into each one of these. The patient expectations, again, is so critical. A lot of it is because it's to the degree that you can tap into really into that why and understand what they're coming from or what it must be like. I showed you that picture. Imagine this in your mouth. Imagine trying to eat with that. And just enjoy life with that, taste food with that. It's very challenging. So patient expectations defined as this. What do they, the patient, expect their restoration to feel like, function like, look like, and also cost? Cost has to be tied into it, but don't let cost be the first thing that you lead out with. And also understand that, really, that cost is really like the third reason that a patient that says no thank you to the treatment. Sometimes they disguise cost because that's what everyone can be familiar with is money. But it's really understanding what their expectations are and what is their why for that. So you need to know what they expect it to look like, feel like, and function like. Once you know that, you know what your restorative options are. And today we're talking about the Locator Overdenture. Then it's about what are you going to fabricate to meet that expectation? If a patient's expectation is that they never have to take their prosthesis out of their mouth, well, an overdenture is not going to do it for them. Yeah, maybe their complaint was that, when I chew, my denture, keeps coming out, or when I laugh, my denture's propelled out of my mouth. Those are part of the why. But if the other part, that's why I say if they peel back the layers to know what their why is, because if you find out that their other why is, I'm tired of taking these out and scrubbing them, and putting them back in, that this is not the right treatment modality for them, and you need to take it to a different level, and that adds more cost, more time, possibly, more complications, possibly. So, and maybe even more adjunctive procedures to meet that expectation. But my friends, the key word here is pre-surgical. This is when you're in that dating phase, so to speak, where you're determining, once the implants go in, you're married to that patient to meet that expectation of theirs. So it's very important to make sure that you're going to be able to meet those expectations and make them happy, you're happy, and just make it a win-win. So now that we know what we're going to make, then we need to understand the biomechanics behind that, because different types of full arch restorations have different requirements, and there's similarities with some, but even the occlusal scheme, the way you set up the occlusal scheme is different. Understanding about cantilevers, and there's so much more to understand. But we're going to keep this very basic today, because the good news is the locators is probably to me, and I've been doing this a long time, like I said, there's nothing more rewarding, honestly, when you solve a patient's problem, and I don't mean just a problem, but I mean really a life issue that affects their quality of life, and you can change that for them, and their tears in their eyes, and they tell their friends about it. It's a great practice builder as well. So you're on the right path here to learn about implants, to learn about overdentures. Then it's now that you know how you're designing that case, the team concept is again sharing that information with everyone in the team, making sure that once again we are always focused on the patient. Without the patient, we're it is that mental gymnastics. You're not going to knowledge is power until it's applied. I mean, knowledge is not power until it's applied. So, we want to be able to apply your expertise and your knowledge and to support and help these patients. So, what do they expect their restoration to feel like, function like, look like, and cost? So, here's some points about this. These are questions to ask the patient and understand to make sure that you've checked off these boxes. Is no movement of a denture real important to them? Because even with a locator, if we did two locators, there's still going to be movement. Now, it's not going to be propelled out of their mouth. It's going to stay within what you would refer to as a functioning position, meaning in occlusion. But there is going to be movement because you cannot have a full arch of dentistry, of occlusion on just two implants. Or if you think about it, you wouldn't do a roundhouse bridge, a full arch bridge with only two abutment teeth, two say your canines, and build a whole arch. It just wouldn't happen. Well, it's really not too much difference because implants are replace are to call it tooth replacement therapy because the implants replace the not only the clinical crown but the root. So they're root form implants is another thing that they call them. So if they say that I don't want any movement, I hate this fact that it moves, it feels like it's broken all the time, overdentures is a locator overdenture is not going to be the right one for them. But if minimal movement is okay and understanding what that is, by the way, using models are very important to have. So a patient, it's their kind of test drive, if you will. You can't put a couple implants, put two implants in their mouth as a test drive and try an overdenture. Hey, do you like that? Okay, now here's put four implants in. How's that? So the only thing that you can really do between verbal communication, showing pictures, models take it to another level when they can snap on and try to pull that denture off. So very worthwhile. They're not cheap, these models, but do have those models for you and for your team members to utilize to communicate to your patients. It's about helping them to make informed decisions about their long-term oral care. And because if they're confused, their decision is not to make a decision, then often that indecision gets hidden by saying, "That sounds great, doctor, really wonderful, and you seem like a really knowledgeable clinician, but it's more money than I can want to spend." It may be money, but the best thing to say at that point is, "I can appreciate that, Mrs. Jones. Let me ask you something. If you won the lottery today and money was not an object, would you go through with this treatment?" And then shut up. Count to 10. Not like 1, 2, 3, 4, 5, 6, but just in your mind, count to 10. Give them that pause, the pressure of silence. They're thinking about how to respond. You ask them a very good, valid question. Would you do this? And if they say, "Oh, wow, yeah, I'd love to do it." Okay, then it is money is an issue. And then you have to figure out, is there a way that you can do financing, payment plans or whatever. But here's what happens most often, very often, is they say, "Oh, that'd be great to win the lottery. But that surgery, that I don't know about that surgery." Stop talking about money. Start talking about the procedure and making them more comfortable about it. What part of the procedure are you concerned of? Maybe you need to utilize other patients for some testimonials. Maybe there's a reference that you can give them of a patient's name to call up or to speak to. But don't, you want to talk about what their issue is, not what they're kind of pretending it is or that facade that they've created. And you need to do that without accusing them of lying, of course. So, but again, it's a very emotional thing for these patients. They've been living with it every day. They wake up, they go to bed, all through the day. Some patients are dealing with this. Is maybe just more of the improved stability of the current denture. And ask them in their words, what do you mean by that? "I want my denture anchored in my mouth." Write those words down. When they say anchor, use their terminology. They have, then when you're talking to them, you say, "Well, let me make sure. Here's the things that you said you would want as a result. You'd like to see don't say your denture, you would like an implant supported or an implant supported, tissue supported, implant retained, tissue supported denture, correct?" They don't understand that. You want your teeth anchored in your mouth. Is that what I'm hearing? Okay. Then you can say, "Here's the things you said, and here's the things that this type of treatment modality that I'm going to present to you addresses those issues." But it's important to use, so please write that down. Use their words. It may not make sense to you. It makes sense to them. And then, another big one, this, my friends, is missed. And it's about bone loss. Now they may not understand bone resorption. You know what? Type in bone resorption on your computer after this sometime today or tomorrow, and it's going to underline it. Even with, I haven't done it with AI. I'm going to do that to see what AI says. Bone resorption gets underlined because it doesn't even understand it. But bone resorption is, bone loss. But here's what patients need to understand, okay? So clinically, we can look at this and say, there's different stages of bone loss, right? To the degree they can understand that, but here's what they understand, and this is what your challenge is how do you get them to see it this way, where what it really means is they're losing their face, they're losing their lips. You'll hear patients say this, older patients have been in dentures for a long time. Someone may say to you, I just want to have some place to put my lipstick. I don't have any lips anymore. It's because of the bone resorption, the bone loss that they have, that now they don't have the lip support and everything starts collapsing intraorally. And the one on the right, that's a sad stage. So, they want to get rid of wrinkles. And you know what we can do with dentures? There's a lot we can do with filling out the lip. And to a degree, you can help remove wrinkles, but be careful about over-promising on that. But here's a great image, and you can, look for images online, but this says a lot. And I've showed this to patients many times. I had this model, and it's just I'm going to show you what this model's coming up in the next slide here. But you could that's just a shade tab off, a tooth off a shade tab that I just glued onto a model, and this is what's happened in your life. I'm sorry, Mrs. Jones, this is, at one point in your life you were here, like you see on the left, but this is where you are today. And so this is what we're faced with. Now, the other thing, I like to show this to patients early on when you're thinking that they may be getting into the need of a denture, that you haven't lost all this bone. And so here's these models. They're available from Salvin Specialties. You can probably get them I'm sure you can get them on Amazon. These are nice. They have magnets that they can come off of the board, so a patient can touch and feel them. And then what's neat also is, radiographs. It's amazing. Patients actually understand radiographs when you can kind of point out, and I'm sure you all have already done this, but you'll be doing this in your practice as well. But here's a clinical view of what that looks like, and then there's the 3D of it, and so forth. And what we do know is that you're going to continue to lose bone if we don't do something. Implants have a nickname. They're bone maintainers. What that means is that when the body thinks that implant is a root of a tooth, so it has a purpose. And through function of the prosthesis to the abutment to the implant and the implant to bone interface stimulates the bone. It says to the bone, hey, you have a reason to be here. So you don't get dysatrophy from that. So you want to say to a patient is that, here you were maybe 10, 15 years ago, and today you're here. And we know if we don't do anything, at some point you're going to be here. And by the way, my friend, if you get to this point here, the second one from the bottom, it becomes more challenging to restore you. And then you can refer back to that picture, with that shade tab and, all that bone that's been lost. But the other thing is, this is going to cost you more, and it's going to be because we're going to probably need to do more implants because we can't use as long implants that we'd like to for strength and for support from an engineering and biomechanic perspective. And on the very lower one, this is, we're back to doing what we did, 30, 40 years ago with subperiosteal implants. So they need to understand this. In fact, it's so important that there was a survey, a very comprehensive survey done. They found out they went to patients who were given implant treatment option, and the patient said, no, thank you. And when it was explained after they said, no, thank you, when it was explained to them really what bone loss causes, and they understood it and their own, their perspective, they understood it. 65% of people said, I would have said yes to the treatment had I known about bone loss. So, and by the way, this website, missingteeth.org, has a lot of great patient information. It's generic from any support of any manufacturers or laboratories. But check that out for yourself as well and see if there's other information to support you there. So let's take a look at this option for the fully edentulous arch. And the locator, which we're really focusing on today, I get a lot of questions asked. Of my 40 plus years in this industry, I spent 20 years with implant companies and 25 with laboratories. And what I get asked all the time from doctors, because they get asked from patients, or if I'm there chairside with them, is they want to get rid of the palate in their upper denture. They can't stand the palate. It affects taste, hot and cold, especially new denture patients. If you haven't experienced it already, you will. They, drink coffee and they burn the back of the throat because they don't taste, they don't sense that until it's back too far to do anything about it. So they want to know, how do they get rid of the palate? Well, you cannot get rid of a palate in a two implant maxillary overdenture. That is a short-term uh, re, appliance or prosthesis for the patient. I won't even say it's a short-term fix, because even though the denture can move and go into be supported by the edentulous ridges, it's too much for those implants typically. Now, maybe you have an 80-year-old, a lower denture. There's maybe some conditions for it, but please know that you're young. You're going to have a long time in your practice, and if you have, say, you have a 50-year-old or a 60-year-old patient, and they're going to be using this quite a while. 4 implants is a minimum, and really you should talk with your laboratory about getting a metal reinforcement within that prosthesis. Our newer materials, our printed and milled denture materials, are much stronger than the methyl methacrylates that we are still using today every day, but what we've been using for 50 years. So, but the metal reinforcement is a great way to build long-term success to these cases. When we talk on our next presentation on the 14th of April, I'm going to get more into the clinical technical. This is setting you up for that part, today's presentation. And just know, if you want to go to the hybrid or something that's going to be screw retained, it is a minimum of 4 implants, 4 to 6 implants. Keep in mind, there's a saying, all on 4, none on 3. So, I think it's best, whenever you're planning for something more fixed than the locator, over design, over engineer. And I don't like using the word over. I think it's appropriately engineer, appropriately designed, meaning 5 implants, because if one's not able to load, you still have 4. If you had 4 and you can't load one, now the patient who's expecting to leave with a fixed prosthesis or a screw retained provisional from surgery is going to leave in a denture. So that's not our today's topic. I've got a lot of information more about that. NDX has it on our website and our education website. I'll have a lot of webinars fully narrated to walk you through that option. And then fixed bridge work, if you want something more of what they call more like crown and bridge, you need more implants. But when we start, see, we're talking about more implants. But what we do know is that more isn't always better. I mean, there's a lot of implants right here, but my gosh, this isn't really helping the patient. And I'm not, this is just something that you'll see a lot of things that'll just make you say, how in the world did anyone ever come up with that thought process? So when it comes to attachments with overdentures, you have two categories. You have a resilient attachment and you have a rigid attachment. And a resilient means that it's going to allow for movement of the prosthesis, okay, which is going to be our locator. Your rigid attachments are going to be usually involved with your bars, like a bar and clip, where there's really not movement, so to speak. It helps to retain the denture in place more fixed. It functions biomechanically more like a fixed prosthesis, but it still is removable by the patient. So again, here's your main options for a full arch. We're going to focus on the overdenture with locators. So what are some of the benefits? So what's really, a real benefit is it's a minimally invasive. In many patients, you still need the CT scans. You really should. And that should be a standard of care. But you could do a tissue punch, not even raising the flap, place a minimum of at least 2 implants. And based on the quality of bone, you may be able to, and if they have an existing denture, convert that denture right there, place implants, convert the denture, and they leave with a retained prosthesis, and it changes their life. This is powerful. This is rewarding dentistry, and financially, it's rewarding as well. It is an implant retained, meaning the attachments are kind of retain it, but it's tissue supported. When it goes into function, that it's going to go onto the edentulous ridges, which prevents overloading of the implants. And it does significantly provide that additional retention for those patients who say, my denture is too mobile, all the issues that we talked about a little bit earlier. I just referred briefly to the retrofitting existing denture. We're going to show you how to do this in part 2, how to do this very predictably. It is not rocket science to do it, and you all should be doing this for patients. It's a great service to do for them. And the other thing is, mentioned already, implants, nicknamed bone maintainers. If you just put implants in and never restored them, you're going to help to maintain the bone. But a real key, I think, with the locators is the fact that you can retrofit a prosthesis. Yes, it's maybe less money to you, but it's a great service, great practice builder for the patients, because not all, if the dentures are maybe too broken down to be retrofitted, but you could do that to give them the ability to say, wow, this is really great. They save up money, then you get the new denture and you just convert a new denture to those existing implants and attachments. So the there are some drawbacks with it. It's still going to have some slight mobility, so you don't want to. You make sure they're aware of that. You don't want to hide that, because it's going to come back and bite you, no pun intended. Bone will continue to resorb. These dentures will still need to be relined, because when the function loads are applied, the denture has that movement that will go onto the edentulous ridges, and so it does still cause bone resorption, but at a much lower pace than than a normal denture. So there will be a need for relining down the road at some point. Maintenance, a denture is easy. Pop it out, rinse. So they do need to do a little more flossing around the abutments. So just, things to talk to the patient about. Understand that, once you place the implants, it doesn't mean they're going to be there forever. They still need to maintain them. And the inserts will, that retain that wear. By the way, I'm going kind of fast. I realize that. This is being recorded. You can come back and watch this. You can pause it. You can rewind it. You can take notes. So I want to make sure I get my information out to you. So please don't worry if you feel like you're writing a note and it doesn't happen. You're going to be able to have total access. Adam and Heather have access to get all this information and help you where to find this information. When we think about doing an overdenture, we look at, setting it up for success. The minimum bone height really of available bone that's going to be where the implant can be placed. We're looking ideally like 10 millimeters, and the width of a ridge about 5 to 6 millimeters. Restorative clearance, we need to consider about space from, for the prosthesis, for the components. And so what we do know that for an overdenture, I mean to say lower, for a locator overdenture, that we're needing at least 5 to 6 millimeters above the tissue. Now, that's not including a denture tooth, and I'm going to show you more about that coming up here in a couple of slides. But inner arch space needs to be evaluated. A lot of times these patients have a closed or collapsed vertical, and they need to have their vertical open, which is a plus. And that's another topic at another time, to talk about how to find the patient's vertical dimension of occlusion, and then how to deprogram and reprogram the musculature to a new proposed vertical. We can have more conversations about that later on. Your all on X type of cases, you're looking at probably 15 millimeters of inner arch space. We can get down to lower numbers, maybe 11, 12 millimeters based on the material that's used. And then once again, finances, patients' hygiene, their home care. Are they going to be compliant? Are they going to come in every 6 to 8 months for a recall? These patients need to they may not have seen a dentist in 5, 10 years. And because they get implants doesn't mean, that they still don't need to come see you. They think, I got a denture, I don't need to see you anymore. They still need to come back because, one, you want to check them for for cancer, oral cancer, different issues like that. The mouth is a telling story of a lot of things going on with their health. So you want to see them routinely. So when we're talking about space, the things to look at is your bone resorption. Look at where, there's classifications of this resorption. And when you have bone, that's kind of gives you the smiley, the green, hey, there's this AB classification. C and D, you got to be thinking this a little bit more. What's the opposing arch? What's the musculature like? Is there parafunction? When you get into E, that becomes a whole nother story. And this might be the refer out type of cases. And C and D might be cases that you feel like you might need to refer out. Um, so it's just helping you to have information to make an informed decision for yourself and informed decision for your patient. So why are locators so popular? I've been involved with locators. I mean, I'm thinking back to and actually into the late 80s and early 90s. But this is why. Look at this. They are like half the inner arch space is required for these. And so when we're looking at, determining do you have room for the prosthesis, because you want to know this pre-surgically. By the way, I'm still in patient selection here. No implants have been placed. So if you find that some of these things I'm sharing with you don't line up, then this stop because you're not going to meet their expectations. So you want to look at the inner arch space, but take a look at this image now. Here, you're still, if say those implants underneath end up directly below the tooth, well, now you have to have a height of a denture tooth, and anything that's going to be aesthetic and based off it's a mandibular arch, a maxillary arch, you could range from 4 to 5, 6 millimeters here. Then you need some tissue thickness. Then you need the componentry. So you're talking about maybe 9 to 11 millimeters from the platform of the implant to the occlusal plane to restore these cases. So you need to make sure that you're looking at restorative space when you're evaluating the patient. Then the other thing is in selecting, and labs can help you with this, but if you're going to be doing some of these chairside retrofits where you're maybe bypassing the laboratory, you need to know this information about cuff height selection. And please know this, all locators and locator lookalikes, when the attachment seats onto the abutment, it's going to cover 1.5 millimeters, the top of that locator abutment. Then the below that is where you need to have some height here. If you don't get a tall enough abutment, then what can happen is you can have tissue invagination, but there's no ability for, it's very challenging for a patient to try to clean this. It can cause more sores. And so you need to have the proper height of abutment. So ideally, we're looking for like a 2 millimeter cuff height above the tissue. And when it comes to occlusal forces, there's really with implant dentistry, I talk about three types of forces: the compressive forces, which is putting together forces, push things together; tensile is pulling them apart; and shearing forces are the most detrimental in implant dentistry, and those are the off-axis ones. That really becomes more of a play when you're dealing with fixed prosthesis, single unit implant crowns. That shearing force is a bigger issue. 65% weaker the bone implant interface when you're dealing with shearing forces. So we want to be careful to look at that. Bone quality, you all are learning about bone quality, but just know that in patients, this is good for patients to know too, but what does bone quality mean to a patient? You ask them, it's nothing, but here's what it does mean to a patient. When do I get my teeth and how much does it cost? Because in poor quality bone, you're going to need more implants, more cost. Poor quality bone, you're going to need longer time for the implants to integrate before you maybe go to a final prosthesis or even get to a provisional prosthesis. So, bone quality, explain that to a patient. Talk to them about their bone quality. Use phrases like oak wood, balsa wood, styrofoam, posterior maxillary, almost like styrofoam. They need to understand that. It helps them to understand your treatment plan and the rationale for your treatment plan. Then you got to look at the available bone. Bone is evaluated three-dimensionally: height, width, and length. So look at bone like that. A panel is only going to give you, length and height. It's not going to give you that critical third dimension, because when we place implants, we want to see implants that are going to be about 1 to 1.5 millimeters of bone around the implant. Now, when we get into recording the video and recording the bite, we know that this is not an easy task to do with these patients. Are you guys hearing the sound? Heather, can you click on, can
Yes,
you hear
we
the
can
sound?
hear.
Beautiful.
We can barely hear the sound of the video if that's what you're looking for, Jeff.
Going forward like a bulldog. Try to force that. Just open just a little bit. Now just relax. Back down. Back down your back feet. Okay, come on down.
I don't know if you can hear, but she's clicking. she's trying to close down. And, you know,
Right, tongue up on your mouth.
oh, the tongue in the roof of your mouth. That's a good trick. Ah, all right. You've heard about that many times. Put the tongue in the roof of your mouth. Okay. You may have heard the phrase mush bites. I've been sharing this for almost literally probably 35 years. And here's what you're going to do. Yes, I'm not saying this is in lieu of face bows and doing all the other things that you're learning that you've learned and that you're maybe even implementing. But here's something that is going to help with getting a more accurate bite if you're just doing what we call a mush bite, where the patient's just biting into maybe some bite material. But here, when you tell the patient, and you can do this, put the tip of the tongue at the roof of your mouth. Okay, you put the tip of your tongue at the roof of your mouth. Um, is one thing, but put the tip of the tongue at the junction of your hard and soft palate. Please do that. Now, with your tip of your tongue about the midline, posterior as far back as you can go, the junction of your hard and soft palate. Now, try to move your mandible left or right and don't move your tongue. It's basically physically impossible to do that. So part of the challenge patients have is they don't have proprioception with dentures and they're trying to close down, but you take a ball of wax and you make a little pyramid of wax, like a little point of it as you see in the right image. And you put it back on the extension of the occlusal rim, and you show it to the patient and you say, now, when I have you close down, I want you to put the tip of your tongue and on that little ball of wax. Because if you, well, I should say, now you did it way back, you put your tongue posteriorly, put your tongue just behind your anterior teeth. Okay, that's the roof of your mouth. I can move my mandible and my tongue doesn't move. So this is the idea, is to get the patient, don't just tell them put it at the roof of your mouth, give them a physical target. They can see it, they can feel it. Now when they close down, when we go into functional closure, our mandible does this. And when you're closing the vertical, you say a little bit more, and stop. They stop left off eccentric, right off eccentric. So the tongue now, instead of being your enemy fighting the tongue is going to act as a centering mechanism to help get you in more of a pure functional closure. Try that. I think you'll find that that will help you. The other thing I want to share with you, the study models. It's, the lab needs to see. A lot of these patients say, oh, no one knows I'm wearing a denture, so make it just like my new one, just like it. And so you want to share with the lab that information. So what happens is you tell the assistant to take an alginate impression of their denture. They put the denture in the alginate tray and pour the model, and this is what you get. All we get here is the mold and the arrangement. We have no idea. The two critical things in denture reconstruction are the positions of the centrals. Where are they incisally and where should they be labial palatally? You get that, a good bite and impressions, then denture reconstruction fabrication is much more predictable. So here's what you're going to do with your assistants starting today even. Tell them that, or you doing it, however this, you're going to take, before the alginate sets up, roll some alginate material over the peripheral border. Don't lock the denture in, just roll it over the anterior flange and the posterior extension of the denture. Now, when you do that, what's going to happen is when the model gets poured, now look at this. Now the laboratory or yourself, if you're going to do your own occlusal rims, you have a definitive measurement. You all were taught 22 millimeters for a maxillary in the anterior, 18 for the lower, and then, to the retromolar pads and, 5 millimeters in the max. This is to what they have. So if the patient wants their teeth longer, if that's measured out at 23 and they want them longer, then tell the lab, make it a 25. The lab has that measurement. You're not guessing so much at this. So you can eliminate a lot of the variables with dentures by this is 15 seconds, 10 seconds to just roll the material over. Posteriorly, look what this does. Now you get to see where the extension of that denture is, measure that out, and you can tell the laboratory or the lab can have it, and they're just go, great. Now we know where the incisal edge of those two centrals need to be and the facial. And I would say, my friends, anytime you're doing occlusal rims and you have this kind of information, tell the laboratory to go ahead and just put 6 anterior denture teeth in, posterior bite blocks, and that way that you can do an aesthetic try-in on that bite registration appointment. It could save another full appointment, but that way you're getting, you're getting more things done in fewer appointments. When it comes to denture teeth, your laboratory technicians should know this, but just know that, the flatter the ridge, the flatter the occlusal plane should be to keep from displacing the denture and causing those shearing forces. Also, it's very important, I think, to be able to have, tools. This is a very inexpensive, I think it's less than $20, somewhere around there. Again, this is available through Ivoclar. It's called a bite plane. Some of you, have all heard the phrase about a Fox plane. But what this is going to do is going to help you to get the occlusal plane lined up with the inner pupil of the eyes, and this way, if the rim is off, you can adjust the rim, or you can put some bite tray adhesive on here, put some bite material on here, and you go in the mouth, and you can, before the material like blue mousse or something, before it sets up, get that parallel, and then you can send that to the laboratory. Then when they're articulating it, they can make sure that it's kind of a poor man's face bowl, if I can say that. Not to say don't do the face bowl if you're doing it. I just know a lot of people aren't doing face bowls. So we need to do things to help us to get the plane of occlusion, because that running downhill is a nightmare, and it happens way too often. Then your other what you're looking at from frontal and then from a lateral perspective is the mid-trachea of the ear and the ala of the nose. You want to be parallel with a line there as well. Okay. Then finally, I'm going to wrap up here and to be able to take a couple of questions, hopefully. So when you're thinking about the placement of the implants, this is from Dr. Carl Misch, a wonderful book, many books that he's provided, written over the careers. But there you see the mental foramen here is if you divide that into 5 equal sections, A, B, C, D, E sections. And when you're thinking about implant placement, it's just not an arbitrary place to go, because what we see happening is that, yeah, patients can say, but right now I can only afford 2 implants. And that could be very true. But 2's the minimum. 1, you can't do anything with 1 implant. So 2's the minimum. Look at placing these 2 implants in the B and D position, because what happens so many times is the patient finds out either one, that procedure wasn't so bad after all. Okay, I was really afraid of the surgery, but or they saved money up now, and 2-3 years go by and they've got some more money. They want that fixed prosthesis, they want that zirconia hybrid. But by doing this, it allows you to what we call an upgrade from those 2 existing implants. Maybe you add 2 implants and you add them into the A and E position. If you're doing a bar overdenture, you leave room for a clip right here in the anterior. But if you're going to go with 5 implants, once again, by positioning those implants in the B and D position, it allows you to upgrade that and utilize those implants. I'm very involved. Pretty much my life revolves on the all on X, all on whatever, the full arch reconstruction cases. And I cannot tell you how many times we get cases with existing implants, and unfortunately they need to be removed because they're not in the correct position for what we need to establish a new prosthesis, a new vertical, etc. So this is something you all are going to be in business for a long time here. So you need to be looking at things that's going to help you long term, so that you're not regretting decisions that you made in the past. So again, by thinking about this, it keeps the door open for you and keeps that patient a good reason for coming to you. So having said that, I'd like to say thank you so much for your attention.